I'd like to welcome those of you who are entering the webinar. We're going to start in like 2 minutes as people come in. So thank you for joining us. And again, we're going to start in about 1 or 2 minutes. Thanks. All right, it's 6 o'clock. So some people are still coming into the webinar, but in the interest of time, let's get started. I want to welcome everyone to, I think, our 13th COVID conversation series. My name is Dr. Eric Ball. I am one of the board members of the California Immunization Coalition and the district vice chair for the American Academy of Pediatrics in California. And I wanted to welcome you to tonight's conversation. A few housekeeping notes. All lines are going to be muted during the program, but we do have a question and answer box, which you can utilize to reach us so that we can ask questions to the presenters at the end of their talks. The webinar is going to be recorded and will be posted on the California Immunization Coalition website, as well as on our YouTube page. And we actually are live streaming this on our YouTube page as we speak. Next. And as always, our gratitude towards our sponsors, which are the California Immunization Coalition, which is a public-private partnership in California of people like me and all the presenters who are trying to encourage immunizations throughout California. And then also the American Academy of Pediatrics in California, which is a collaboration of 3 of the California AAP chapters, and we work together to do advocacy and education throughout the state. So thank you to CIC and the AAP California. Next. And then our moderators today. So I am going to be joined by a special guest today, Dr. Jasjit Singh. She is actually the president of the California Immunization Coalition, and she's the assistant division chief of infectious diseases at Children's Hospital of Orange County, which is also my affiliation. She's also the medical epidemiologist for CHOC and our president. And then again, I am a primary care pediatrician at the CHOC Primary Care Network. And with that, I'm going to turn this over to Dr. Singh, who will introduce our first presenter.
Good evening, everyone. Thanks for joining us. Glad to have you here. And I'm very excited about tonight's program and about our presenters. I think it's going to be a great hour. So first up, we're going to hear from Dr. Pannaraj, who is an associate professor of clinical pediatrics and molecular micro and immunology at Keck School of Medicine, USC, and a fellow Peds ID doctor at CHLA. She serves as the director of the Pediatric Immunization Advancement Lab and CHLA's Pediatric Global Health Education Program. Dr. Pannaraj's global research focuses on maternal and infant vaccinations, optimizing vaccination strategies in the community setting, and improving vaccine immunity. Dr. Pannaraj serves on the board of directors for the California Immunization Coalition and is the current vice president right now. She's been appointed to an American Academy of Pediatrics expert panel for global immunization initiatives. And Dr. Pannaraj completed her ID fellowship at Baylor and her MPH at the University of Texas Health Science Center. So we are very glad to have Dr. Pannaraj here with us this evening, who's going to present an influenza update. Thank you so much.
Thank you very much, Jasjit and Eric, for having me here tonight. So today I'm going to talk about influenza. We're starting to see quite a bit of influenza, and we've had some strange seasons before this. So I think it's very important to update you all on what's going on with flu. So I do have two disclosures. I received funding from AstraZeneca and Pfizer for studies not related to influenza. So today we'll review the burden of flu. I'll use influenza and flu interchangeably. So flu over the last few unusual seasons, and highlight updates and practice pearls and recommendations for flu vaccination, as well as discuss flu treatment recommendations. So this is the US influenza burden every single year since 2010. And you could see that it varies each season, but in a typical season, we can see up to 45 million people get infected. This is US data. So 45 million people get infected, up to 500,000 individuals hospitalized, and between 23,000 to 51,000 deaths every year. And it actually costs the US economy $81 billion every year due to, hospital care, lost work, and other that economic burden. So, what happened last season? So as you know, we had the flu. So typically we see the flu December through February, March-ish every year here in California. We're a little bit later than the rest of the country. And then when the pandemic hits, that the following season, 2020 to 2021, we didn't see much at all of flu. And then 21 to 22, this is what happened. So in November, we started to see some, and there were actually two peaks, but the second peak actually extended pretty far along. And so even in May and June, we were still seeing quite a significant amount of flu. Still overall, it's this dotted blue line here. Overall, the numbers were lower than previous seasons that you can see for all the other colors. So, so last year and the year before, the year that COVID, it was considered low severity. In a moderate severity year, you can see the hospitalization rates listed here by age, with the highest number of hospitalizations in the under 5-year-old and then the over 50-year-old groups. This was much lower during the 2021 year and started to come up a little bit in the 21 to 22 year, but not quite where we were before. Now in children, I know there are many of you on the call that take care of children. In children, we see that about 9.3% of children every year develop symptomatic infection. But of those, the ones that are admitted to the hospital, there could be significant morbidity, including 20% requiring ICU care, 5% developing mechanical ventilation, and 8 to 10% experiencing neurologic complications. And many of these children, so you could see the characteristics of these children by year in the table at the bottom of your slide. So 42% in the 2019 to 2020 year had at least one underlying condition. That could be asthma, neurologic issues, or obesity. But what that also means is that nearly 60% of the children are otherwise healthy and yet still end up hospitalized with flu. These numbers changed slightly in the 2020 and 21 seasons, but I think this is important to note so that you remember that it's not just those with underlying issues, but even otherwise healthy children do end up hospitalized. Sorry, and I just want to make a point there that of the deaths that we saw, especially in that year, 74% of those who died were vaccine eligible but unvaccinated. So we also see significant health disparities with flu. So when you look at all hospitalizations, ICU admissions, and in-hospital deaths, the Black, American Indian or Alaska Native, and Hispanic groups all have significantly higher number of hospital admissions, higher number of ICU admissions, and higher number of deaths compared to the white population. And it doesn't matter what age group you're in. And what makes things a little worse is that the influenza vaccination rates are falling. And this may be due to some of the hesitancy that's sort of overflowed from COVID-19 vaccines, or the lack of confidence of people thinking, oh, we're just going to have another mild flu year because the last couple have been mild. But we don't really know what to expect this season. Flu, and actually all the respiratory viruses, they've been very unpredictable since COVID-19 started. And so this year we may have flu and SARS-CoV-2 both at the same time, which means many, many more sick individuals and overflowing hospitals. One can have co-infection with flu and SARS-CoV-2. We're also seeing in children a higher number of RSV, so you can have co-infection there. And many experts believe that this will be a much more severe season compared to the last two seasons because of the reduced population immunity, given that we had fewer infections over the last two seasons. We also have relaxation of social distancing measures. So the masks that we were wearing before, those are really coming off now. And so we may see a lot more flu this year. Here's the data, the surveillance data in the Southern Hemisphere. And so the beginning on the left-hand side of your slides, you could see typical seasons, nothing in the 2021 year. And then 2022, so normally in the Southern Hemisphere, they see flu over the summer. But this 2022 year started in about December of 2022 and then continues. And this figure actually goes all the way till October 9th when I pulled this data. So they are continuing to see flu there. And if you look at the amount that they're seeing, it really does is at least the same or maybe even more than what had been seen in the previous seasons. So if what happens there, what happens here, then that is definitely of concern. And here is our data in the United States up until October 1. And I'll call your attention to this, the right side of the figure here, which is the current data. Starting in October, we're starting to see a rise in flu detected in the United States. And even here in California, last month, we had an outbreak affecting the UC Berkeley campus and many smaller outbreaks especially affecting high school students in San Diego. And there's some reports in Orange County as well. So it's definitely coming. It's here and it's going to increase. So how do we prevent flu? Well, so the vaccine is recommended for all persons 6 months of age and older. And there really aren't many contraindications at all. So in your head, you should just remember it's recommended for all persons 6 months of age and older. This is the recommendation there. If supply is limited, then you vaccinate those at highest risk, but we don't think that will be a problem this year. So who are at the highest risk for flu complications? So those that are very young, under 5 years old and over 50 years old, people with chronic medical conditions, including pulmonary, cardiovascular, renal, hepatic, neurologic, hematologic, and metabolic. That includes also diabetes and obesity. Those who are immunocompromised, pregnant, children who are receiving aspirin or other salicylate-containing medications, those in chronic care facilities, and American Indians and Alaska Natives, and those with extreme obesity, as I mentioned earlier. So what's new about the flu vaccine this year? The 2000, I'm sorry, the H1N1 strain is actually the same as in previous years, but the H3N2 virus has been updated. Last season, we saw predominantly H3N2. And the influenza B Victoria strain has been updated. The Yamagata lineage is the same. The other update is that the cell culture-based inactivated flu vaccine is now approved for children 6 months of age and older. Before last season, it was only approved down to 4 years of age. And this was based on safety and immunogenicity data in 2,000 children, 6 to 47 months of age. So those are really the two main updates for the flu vaccine. It's important to remember that there is no preferential recommendation. So any licensed flu vaccine product that's appropriate for age or health status can be given. And there's no, so whether it's cell-based, recombinant, the live vaccine, or the inactivated, there's no preferential recommendation for either one. So if you have children that don't want to get their a needle stick that day, or their parents promised them no shots, they can still get the live attenuated vaccine. So here is the one contraindication for a flu vaccine, and particularly for the inactivated flu vaccine. That is anaphylaxis or severe allergic reaction to a previous flu vaccination. And those children should actually see an allergist to determine what component of the vaccine they were allergic to, so that their decisions can be made on if they are able to get flu vaccine in the future. There are a couple of precautions, but these are just precautions, things to consider with the family. If they currently have moderate to severe illness, then you might consider holding off for a little bit. Or if they have history of Guillain-Barré syndrome within 6 weeks of a previous flu vaccination. Do keep in mind, though, if they had history of Guillain-Barré, they may be at increased risk if they actually develop flu infection. The contraindications for live attenuated vaccine are a little bit more. I won't read them all out to you, but you could see them listed here. But in general, any otherwise healthy individual between 2 years old and 49 years old is eligible to receive the live attenuated influenza vaccine. What is not a contraindication? I think this is very important. So any minor illness, if you're seeing a child in clinic or an adult in clinic with minor illness, but with or without fever, they can actually receive the flu vaccine during that visit, so that you don't lose that opportunity when you already have them there in your clinic. And what also not a contraindication is egg allergy. The American Academy of Pediatrics have come out more firm on this, that children with egg allergies can receive any age-appropriate licensed recommended vaccine with no additional special precautions. And this was based on 28 studies evaluating over 4,000 egg allergic subjects, including 656 with severe allergies. All right. So who needs 2 doses? Just a practical guidance. So children under 8 years of age and under need 2 doses if they have not received at least 2 doses in the past. Now, those 2 doses in the past don't have to be in the same season, and they could also be any combination of any brand or type. It doesn't have to be the same brand or type for those 2 doses. And so if they're 9 years of age or older, then they'll receive the 1 dose, the annual dose of the flu vaccine. When to vaccinate? I think this is the most common question that I'm getting right now, especially because last year we saw flu all the way through May and June. But as you can see already, this year we're starting to see an increase now. So children and adults, everybody, should be offered flu vaccine as soon as it's available, and especially those that will require 2 doses. The everyone should receive their vaccine before Halloween. That's the target. For those that aren't able to, then vaccination efforts should continue through May and June, but we should not wait. The flu is here and will be increasing. Everyone should get it now. The vaccine, to make it easier, the vaccine can be administered simultaneously with routine vaccines or also with on the same day as COVID-19 vaccines. The only small exception to that is with the live vaccine. If the live vaccine is not administered on the same day as another live vaccine, then you should wait at least 4 weeks before receiving the nasal spray, the live vaccine. However, the inactivated vaccine can be given at any time. So with that, I'd like to remind you, all the ways to increase flu immunizations. Make sure to review the vaccination status at all visits, and that includes not just flu, but also routine vaccines and COVID-19 in case there's anything that needs to be caught up. Offer a strong presumptive recommendation, and ideally bundle flu vaccine with the other vaccines so that the kids are getting all their shots at the same time. Use consistent messaging across all the care team members. So your front office staff, the medical assistant that's putting the patient into the room, the nurse, and you should all be giving that same message that it's important to get their vaccine. And it's also really important to partner with stakeholders out in the community. So nowadays, pharmacies are able to give flu vaccines, they're able to give vaccines for kids down to 3 years of age, thanks to the experience now with COVID-19 vaccines. And also schools and other community sites are great places to be able to get people vaccinated en masse. So be sure to reach out to other stakeholders, other people in the community to see how we can all support each other to make sure that the community is vaccinated. So I just want to briefly talk about influenza antiviral treatments. There are a couple of updates this year, and I think this is always a question, especially as you see patients in your office or in the hospital. So antiviral treatment is recommended as early as possible for any patient who has confirmed or suspected influenza, who is hospitalized, or has severe, complicated, or progressive illness, or at high risk of flu complications. So those last two, severe progressive illness or high risk of flu complications, those could be inpatients or outpatients. And for all of these, this is regardless of flu vaccination status or duration of symptoms. So even though we know that early treatment, especially within 48 hours, has the best, allows for the best response, the decrease in duration of illness, if somebody is at high risk of complications or is hospitalized, they should get the antiviral treatment anyway, regardless of that duration of symptoms. Now, if you have somebody that's otherwise healthy, then flu antiviral treatment could be considered for those that are not at high risk if the treatment can be initiated within 48 hours. Or if that individual is a close contact of a high-risk individual. So close contact of an infant under 6 months of age, or someone else at high risk for flu complications. These are the antivirals that are available. Oseltamivir is probably what you have the most experience with, and that can be used at any age down to from birth onwards, and whether also in preemies or term infants, and for the elderly. Zanamivir and peramivir are used mainly in hospitalized individuals because it's only available as inhaled or IV. And then baloxavir is another antiviral that's available as an oral agent. It's a one-time dose And it's available for individuals 5 years of age and older. And that lower age was just approved this past year and during this past year. So currently oseltamivir is still considered the preferred drug of choice. But if you have an individual in your clinic that you don't think will stay on the 5-day treatment of oseltamivir, then baloxavir could be considered. For children, baloxavir is only available as a pill, so that might be something else that you need to consider. So, and then there's also the possibility of prophylaxis after an exposure. So this would be considered if within 48 hours of exposure, and you can consider it for any individual at high risk for flu complications, particularly if they're unvaccinated or if they haven't had enough time yet to develop a response to the vaccine, or if they are immunocompromised and therefore may not mount a sufficient response. If the individual is at high risk, you may also consider it if the circulating strains are not well matched with the current strains. So, so of these complications, you could see the most importantly are those high-risk individuals who are unvaccinated or don't have enough yet time to mount a response. So overall, still, even with treatment and prophylaxis, vaccination is still the most effective way to prevent flu. So with that, I will stop and hand it back over to Eric and to Ken.
Thank you so much, Dr. Pannaraj. We in primary care pediatrics have been seeing a ton of flu already, so it's definitely been an early season. And after not seeing very many flu cases for a few years, I actually somewhat forgot how sick those kids are and how ill appearing they are. So I'm happy to hear about those treatments, and we're trying to vaccinate kids as quickly as possible. If you guys have questions for Dr. Pannaraj about influenza, please put them in the question and answer. After the next presentation, we will be addressing questions to both speakers. And with that, I would like to introduce our next speaker, which is Dr. Ken Zangwill, who's a professor of pediatrics at the David Geffen School of Medicine at UCLA, chief of the Division of Pediatric Infectious Diseases, and director of infection prevention and control at Harbor UCLA Medical Center. He's also currently the chair of the AAP section on infectious diseases and is a member of the AAP Committee on Infectious Diseases, who write the Red Book. He served as chair or a member of many CDC, NIH, and AHRQ research study sections or review committees, and is currently a member of the Pediatric Leadership Council for the Society of Healthcare Epidemiology of America. He received his MD from Pennsylvania State University, completed residency at Children's Hospital of Pittsburgh, and served as an epidemic intelligence service officer at the CDC, followed by an ID fellowship at Harbor. And Dr. Zangwill is going to talk to us about COVID and teach us what the word verisimilitude means. And with that, Dr. Zangwill.
Thanks, Eric. Thank you, Eric, and Pia, Jasjit, and Cameron for inviting me. It's really my pleasure to be here. Verisimilitude, sort of realism, reality. So kids, COVID vaccine, and verisimilitude, because we're certainly surrounded with a lot of information that may or may not be correct. I'd like to say as well that I think the last COVID conversation, this forum that actually talked about COVID, was in June. So I hope that some of the background data I present will give us all, get us all on the same page. Now, let's see if this is working. Whoops. Okay, I don't have any relationships to report here. My slides moved. Can you see 3 circles? Did they move for you?
Yes.
Excellent. Okay, so my goal here is for all of us, we're all practitioners, we all see patients, and we're all surrounded by lots of different types of information. So my goal is to help us educate our families and our patients, our older patients, with the most up-to-date information. And then we can vaccinate. I'll talk about vaccination, of course, and mitigation. I'm not going to spend a lot of time on that. That's mainly about therapy and prevention. So just to get us all on the same page, this is as of a few days ago, the community levels. This is on the CDC website. This is an estimate of community spread. It's based on what's in the blue box there. I won't read that to you, but nearly 80% of the country, 75, 80% of the country is in a low community level at the moment. And of course, this can shift and change, but that's where we are as we speak. So that I think is good news. Now, how much disease is really out there? We've moved into an era now where case counts are not reliable, right? Because people are doing home tests, school-based tests, whatever they may be, and they're not getting reported to public health, which therefore means they're not getting reported to CDC and elsewhere. So the standard kind of graph with number of cases probably isn't particularly helpful. So we got to look at other stuff. So here's hospitalizations, for example, as of, I just uploaded the slide yesterday, even an hour ago, to make sure this is up to date as possible. And this is age-based. You can see 6 months to 4 years, 5 to 11 years, 12 to 17, and you can see the curves for yourself. This is one part of the surveillance that we can look at to get some sense of what the trends are over time. The other thing you can look at is wastewater surveillance. You may have heard of this. Hundreds of sites throughout the country are doing surveillance on a frequent basis for the virus. Doesn't mean it's live virus or dead virus, but the presence of virus. And you can see that towards the most recent, towards the right, we've had sort of an increase in the number of sites that are experiencing a decrease in their positivity rate. So again, that's good news. A piece of the pie when we're trying to understand how much disease is actually out there, since again, rapid tests are not getting reported. So I want to update you on where we are as of last week or so. Roughly 15 million cases in the country in children, and that's 15% of the total cases, and children account for about 22% of the United States population. Around 1% have been hospitalized, less than 0.01% have died due to this illness, and there has been MIS-C cases, of course, up above that you can see. And just to drill down a little bit on Omicron, because I want to try to focus on Omicron, because that's where we are right now. If this is the latest and greatest data on nearly 400 kids between 5 and 11 with Omicron, 70% of these kids had underlying conditions who were hospitalized. Okay, these are all hospitalized patients. And that means 30% were not. So that's they're all vaccination target, but we need to understand that a third of these patients did not have an underlying condition, such as asthma or a neurologic condition, and in adults, particularly obesity and diabetes. Nearly 90% were unvaccinated. Okay, and you can see the racial ethnic distribution there and the inequities that go on here. The unvaccinated rate among hospitalized kids with Omicron is twice that among the vaccinated. Now that number used to be much higher, 8, 10, 12, even higher. It's noticeably lower now, but it's still different. About 25% of these kids had what they defined as severe disease, which is a little bit less than we saw with Delta, the Delta variant, and about 19% ended up in the unit, which is less than Delta as well. So Omicron does seem to be slightly less morbid, if you will, than Delta, which is of course good news. But we still have evident disparities. I mentioned one. These are data from CDC, the latest data as of mid-September. And these are rate ratios of cases, hospitalizations, and death, comparing to the white non-Hispanic population. So for example, American Indian or Alaska Native, they have fold change increases compared to white non-Hispanic. In fact, every group does except for Asian non-Hispanics, which are slightly less than white non-Hispanics. So again, these are the disparities that we talk a lot about. And there has been improvement in this over time, I think it's fair to say, but it persists. We see the same trends with MIS-C, similar trends. Non-whites have higher rates. There are very few data with Omicron, which makes sense there are fewer MIS-C cases now. In fact, there's only about 2 per day in the entire country currently. And Omicron, again, is a little less severe than Delta. Pediatric vaccine coverage. There aren't any recent CDC data on the primary series with regards to racial ethnic distribution, but data from January showed clear disparities. The first booster dose, Asian populations much higher, and white populations much higher than all the other ones, and similar trends in the second booster. So we still have our work cut out for us in this realm, although it is improved over time a little bit. So just a couple clinical topics, because these are vaccine targets. So I'm not going to go over all these data, but this is long COVID. There were lots of data that came out, and there have been data that come out in adults and children on long COVID for a long time. Nearly all, I shouldn't say all, but most of the early studies were cohort studies without a control group. I just don't look at those data. These are matched controlled data in children for long COVID. Again, I'm not going to go over all the data, but I will tell you there are large studies from Denmark, 2 from England using very similar data sets, and a big one from the United States. They were matched by various factors that I won't repeat here. And the short story, I think, is that we don't know yet precisely what's going on with long COVID in children. These studies found differences at times in certain symptoms in children compared to a control group, but they were statistically significant. Everything in this column is statistically different, but the actual percentages when you compare the cases versus the controls weren't radically different. So I just want to sort of share that information with you. None of these studies were matched for pre-existing comorbidities or MIS-C, although some of the models that generated the final results tried to control for comorbidities. So the short story with COVID, long COVID in children, I think, is that there is an ongoing and real significant need for controlled data for Omicron, of course. The racial ethnic demographics tend to skew the other direction, more of the white population with long COVID. There is absolutely no consensus case definition for this just yet, but there is an active national effort to fund studies for children, particularly the Recover trial, which is going to be a monster trial with thousands of kids over 4 years. And CDC and the census, they collaborate, has added questions about long COVID specifically in kids in the household pulse survey. So we can look forward to that information. One slide on the available opportunities in case the vaccine wasn't here. Our only very limited treatment options in children, Paxlovid, you've all known about this, of course. I just have the indication. It's a big it's 3 tabs twice a day for 5 days. And you do need to be aware of drug interactions when you use Paxlovid. And there's a website here for you that's a nice pick up drug and see if it interacts with Paxlovid. There's a big trial ongoing right now in Pediatrics Global for Paxlovid because it doesn't exist as yet, but that's pending. And of course, we have remdesivir as an outpatient, 3 IV infusions. And these drugs are really distinctly alternative drugs to these. Frankly, Paxlovid is really where it's at. And if you have to, you can use remdesivir. So let's talk for a moment about vaccination. These are the latest data on coverage. And I'll just share with you the completion of the primary series in children is roughly 60%. That's all children, or excuse me, 12 to 17 year olds, excuse me. And you can see the rates in the younger children, it's of course lower. And here are the booster data. 12 to 17, it's only 29% got their first booster, and under 11, only 15%. So we have a lot of opportunity here. I want to share with you just a few slides on the other side of the vaccine coin, which is the families, of course. One thing for us to try to vaccinate, Pia just talked about flu vaccination, and we need to know what we're working with. These are data from the Kaiser Family Foundation. They do great surveys periodically in a representative sample of adults. And they asked this question just not even a month ago. Thinking about your child between the ages of 12 and 17, do you think you'll get them vaccinated? Pretty simple question. 12 to 17 year olds. And notice, I want you to focus on the green. Definitely not is roughly, by the way, all these tables are going to be set up like this, April 2021. And here are the most recent data in this top line. So notice 25, 30% are definitely not, and throw in another 5 or 10%. So you're pushing 40, 45% that at least the parents aren't going to push to get their 12 to 17 year olds vaccinated against COVID. This is a hurdle for us. 5 to 11 year olds, same thing, except the number, well, roughly the same thing. 35, add 10 or 18, you're up to 45, 50%, don't want it for their 5 to 11 year olds. What about the under 4? Well, you're even higher. And frankly, in September, it's a majority will not get their youngest children vaccinated. So this is a real problem for us. If you ask these families, how much have you heard even about a new update? This is the bivalent. Again, pretty lowish numbers, roughly 50% say that they've heard nothing at all or a little. And if we're trying to work with a family that hasn't even heard about it, that's a big lift for us in the office. All right, so what vaccines are we even talking about? Well, this is it. These are the ones that are available. I'm not going to read all the doses, of course. The new information that you probably don't know, maybe, is that it just came out yesterday that the bivalent booster, which formerly 3 days ago was available only for 12-year-olds and up and only Pfizer, is now available for 5-year-olds and up for Pfizer vaccine and 6-year-olds and up for Moderna. This just happened. This is the challenge. I just gave this similar talk at the AP and it's already different. But here it is. This is great news. So kids over 5 basically have an option, which is nice. Booster, I'm talking about the bivalent here. Not going to go over all the data on this slide, but I think people want to know what is the vaccine effectiveness in children versus Omicron. Try to focus on our interest here. This is 2 doses, 4 studies. These are some data that sort of outline the studies for you. And I've divvied it up into symptomatic disease as the outcome, prevention of, or hospitalization, prevention of. And you'll notice if you just focus on symptomatic for a moment, and you sort of think about the Delta numbers, which was fairly high, 70, 80%, the Omicron numbers are lower. And I probably have known this. And these are the follow-up periods. For example, this one study, 51% protective efficacy or effectiveness against Omicron in symptomatic kids when you looked at them a week to 2 months later. You look at them 6 months later, it's much lower. Give them a 3rd dose, it boosts. Hospitalization was great, 85%, and no change over 6 months. So the symptomatic data are all sort of roughly similar. There's a difference between the hospitalization data between this big US study and the Canadian study. This is what we're dealing with. Slightly less protection for symptomatic disease compared to Delta, and similar to slightly less for hospitalization. These are 3-dose vaccine effectiveness versus Omicron in adults. ED, urgent care, hospitalization, 3 doses. Pretty good numbers for ED, urgent care, which is similar to the symptomatic column that I showed you before, a little higher in these adults. And the hospitalization data are pretty good. Now, this is kind of interesting. Vaccine effectiveness against Omicron transmission. Does it prevent transmission? This is in a jail setting in California state prisons. And if we look at here, if the index case, they looked at index cases in jails and their contacts in the cell. And if the index case was vaccinated, 1 dose, the relative change in the attack rate versus nothing was about a 10% decrease. So it decreased transmission by 10%. 2 doses was about 25-ish%, and 3 doses was 30%. So it does prevent transmission for Omicron, as it did for Delta. This is good news for us. It's not a sort of a huge increase. I mean, but a 30-40% decrease in transmission has significant impacts in a defined population. Okay, so now the bivalent, that's where all the news is at right now. Of course, it was approved for EUA August 29th, I think it was, and that was based primarily on its safety and immunogenicity against the Omicron 1 variant, not B45, and they had some mouse data for B45. Indeed, there's minimal to really no safety, immunogenicity, or vaccine effectiveness human data for B45 bivalent. But they approved this kind of in the paradigm of influenza that Pia just talked about. Every year we have a new flu vaccine. We don't have tons of safety, immunogenicity, and certainly not effectiveness data. And that's the model here. It's also important to point out that you may not know that the companies made other bivalents that weren't 4-5, 2, 3, various things, and they all seem to perform well, i.e. lead to a good antibody response, but they became obsolete because the virus didn't listen to us, and that went away and 4-5 emerged. They're recommended for greater than or equal to 2 months. When you've had, they're not recommended until you've had at least 2 months from your last dose, and they're not for the primary series. And it doesn't matter how many doses you've had after the primary series, you can still give a bivalent, and you should. That's what this is, used after any previous vaccine combination. And this is just the sort of the milligrams of the ancestral strain and the BA.4/5. Both vaccines have both, but at different doses. Just one picture. I'm not a virologist. I don't play one on TV, but here's the receptor binding domain of the spike, right, sitting on the virus. And the white are areas, mutations that are common to B1, B2, B3. You can see that here. A couple other colors here. This red X means it's not in B4/5. That's right here. I think you can see my cursor. And to the left is the other receptor binder domain view that shows the mutations in 4/5. So just to give you some general sense. Adult bivalent trials, because these were considered as well in the discussions about licensure for children or for EUA designation for children. This is in 55-year-olds and above, bivalent versus the old vaccine. And the short story is that the bivalent had superior immunogenicity or antibody production against the Omicron strain, which makes sense, and non-inferior or the same against the ancestral strain. The reactogenicity was the same. The immunogenicity was a little less robust for B45 compared to the original Omicron. Wasn't zero, but it was just less robust. And the only other data slide I'm going to show you on the bivalent is this. This is the Moderna. That was the Pfizer I just showed you. This was over 18-year-olds, a second booster. And the short story is, if you give them a second booster and you compare the old booster availability versus the bivalent, you'll notice the change in antibody. This is a log scale, by the way, don't be fooled. It's a 3.8 to 7.1 fold increase. So 3.8 fold increase when you give the booster, the old booster, 30 days later, you check the titer. But when you check the titer after the bivalent, it's 7-fold higher. This is for everybody just added together. If you look in those who'd never had previous infection, again, twice as much response. And same thing if they had previous infection, roughly. So this is better than the ancestral strain where the levels, the boosting was basically the same between, yeah. Okay, so we have different vaccines, we have different doses, we have different age groups, we have different vaccine effectiveness follow-up periods, and we have evolving data. And I just told you the booster announcement came out yesterday. So all of this is confusing and difficult for practitioners in the real world. So I'm not going to go over this in any detail, but I want to make you aware, if you aren't already. This is a graphic put together by CDC. I actually amended it because I had to add the bivalent booster to the 5 to 11 group because they don't have it yet, to my knowledge. But anyway, this is vaccination schemas for whatever age group you're talking about over here and whatever vaccine you have available or you want. So I just want you to know it's available. This is for folks who are not moderately or severely immunosuppressed. They have one for that group. Again, 6 to 4 years of age, 5 to 11 years of age, 12 and up, and another group here. And lastly, they have Evusheld, which has 2 monoclonal antibodies for prevention in your high-risk patients, your kidney transplant patients, your severely immunocompromised patients. Every 6 months, they can get this. Okay. So why not just do universal vaccine? Well, I don't know. Should we prevent all illness or just severe illness, for example? There's not as much money as there used to be. This isn't Operation Warp Speed. There are fewer animals, I'm told, from people that develop these vaccines. There's only one universal coronavirus vaccine right now in clinical trials. And the other reality is that these viruses, these coronaviruses, aren't necessarily the same. Here's SARS-CoV-1, here's COVID, here's MERS in Arabia and Saudi Arabia and Egypt. And look, only any other cold coronaviruses, they're not very homologous. So making a universal COVID vaccine or universal coronavirus vaccine is a tough game. So a few questions. I think Pia mentioned this. Yes, you can give COVID vaccine with flu. What if you've had prior COVID? CDC recommends you wait 3 months because you've got tons of antibody from wild type disease. Just some terminology here. Fully vaccinated, I was getting confused on this before, is primary series only. Up to date means, did you receive the last eligible booster? Can you mix and match them? Not for the primary series. We're talking about Moderna and Pfizer pretty much. But if you somehow, a kid got the different vaccines in the primary series, don't repeat the series. And here's the answer for the boosters. Can I use the bivalent in the primary? No, not yet. It's just not recommended. It's not, there's no EUA for this. ACIP doesn't recommend this, so don't do that. Does it contain any of this? Preservatives, eggs, gelatin, or latex? No. The CDC site also lists, I swear to God, no nanotubes or microcomputers. They seem like a joke, but we all know it's not. And it actually says on the CDC website that it doesn't contain that. I want to make sure all of us as practitioners speaking with families know there's a robust vaccine safety monitoring system in this country. VAERS, you may be aware of, is a passive system. Anybody can call, patient, practitioner, anybody, or they can do an online form. It's completely passive and signals pop up. The data are just pretty crude. And if a signal pops up, like it did for rotavirus vaccine and intussusception years ago, then they go to something like the VSD, which is a prospective, sometimes retrospective, a retrospective, but big data system that incorporates many integrated health systems to do robust, good methodologic studies. CISA is a system where they take individual children who have weird reactions or unexplained reactions and really work them up. And vSafe, I know you know, is the online COVID process that's new to COVID. And then remember, the FDA mandates that manufacturers do surveillance for at least a year or two. So that goes on as well. One slide on myocarditis, which is sort of the only real important, in my humble opinion, or at least potentially serious adverse event. The rates vary from 0 to 188 per million doses. The second dose and the booster is a little worse than the first, a lot worse actually than the first. Males, higher rates than females. Moderna, a little bit higher than Pfizer among male adults. And the highest risk is 18 to 24, and children it's 12 to 17. Usually occurs in the first week. It's usually very mild. And a lot of people talk about ascertainment bias here. You know, flu, for example, causes myocarditis. But the whole world is so focused on these new COVID vaccines that we have detected a lot of myocarditis cases that mild, that probably would never have been detected in a lesser surveillance system, for example, with influenza. CDC recommends that you avoid a second dose or whatever dose you're at if you indeed have a child who developed myocarditis. But remember, this has to be balanced against COVID illness, which itself causes myocarditis at rates anywhere between 2 and 20-fold more commonly than the vaccine. So keep that in mind. Again, this is similar to rotavirus. The rate of intussusception post-vaccine is far less than the number of rotavirus disease cases that resulted in intussusception that were prevented. So why continue to vaccinate? Well, it remains a potentially serious infection. All of this stuff happens still. Hospitalization, ICU, MISC, and death. And I mentioned before that a third of these kids don't have any underlying condition. Vaccines are effective against transmission that I showed you and all of the above, even though the symptomatic illness is a little bit less than Delta. Vaccine after a series of, vaccine given after infection boosts protection. And new variants, of course, continue to emerge. And remember, the longer that a virus is living and circulating in an individual or in a population, there is a potential for mutation. So vaccination prevents this, can prevent this. So my last slide. Go for alternative data when you're looking to see what's up right now, like the hospitalizations, the wastewater, these things. Morbidity persists, and I've mentioned this already. We do need more data. We're getting it, I think, on long COVID in children. Be attentive to prevention with Evusheld in their high-risk immunocompromised patients. This is the monoclonal. Our racial ethnic disparities in all aspects of this disease have improved, but they persist. We have a disappointing coverage of vaccine, even in the teenagers, particularly with the booster data. 30 to 50% of parents are not interested in vaccinating their children, and it gets worse as the children get younger. That's a challenge for us. Vaccine prevents much of Omicron disease and some transmission. The schedule is confusing and it's always changing, and that's maybe a good thing because we're getting new information and new data, but it's a practical problem in the office. No universal vaccine for coronaviruses in the near future. The vaccine safety surveillance system nationally is robust, and parents should hear that. And I'm sure I don't need to tell this group, but I'll do it anyway. Anything you can do as a pediatrician or a nurse practitioner or a family practitioner, whomever is out there that takes care of children, the more you get involved with any organization or as an advocate or with legislature, the better. And I'll stop there. Thank you very much.
Thank you both so much. Those were great talks, ton of really useful information. Really appreciate it. So I'm going to start off with some questions. We did get quite a few come in advance as people registered. So Pia, I'm going to start with you. You actually addressed several of them in your talk. So one of the frequent questions is, when is the best time to get your flu shot? And I think you made a great case for the unpredictability of the season and the fact that our numbers are taking a steep trajectory upwards right now. And your message was, please get vaccinated now and get your patients vaccinated now. There were also some questions about flu mist versus inactivated vaccine. And I think we all got the message from your talk that there is no preference for either one. I feel like in my own world, flu mist has kind of fallen off the radar a little bit, but good to remind everybody that it is an option out there and can be really helpful for school-based clinics or for kids who are needle phobic. So what I want to ask you about is that there has been quite a bit in the news about the phenomenon of imprinting and original antigenic sin as it relates to both COVID and influenza. Kind of some catchy phrases there for sure. Can you just explain very briefly a little bit about what this means so people have some understanding when they hear about it?
Sure. That's a good question and a tough one to explain simply. But so as you know, as everyone knows, the flu virus changes every single year with that small drift. And that's what makes us get infected. You know, we can get infected year after year after year if we're not vaccinated. And this will likely also be the case for COVID. So the idea of imprinting is that initially, the very first flu strain that you saw, that's where you make your biggest immune response. And then the next year where you see a flu virus that's almost the same, just has that slight different, but otherwise the same, your body doesn't realize that. And it may not make the same immune response because it thinks it knows what it's doing already. And that's not the case. And then with flu, because that happens year after year after year, our immune systems are not as effective in terms of fighting it off. So, so there's some thought that if you get the flu vaccine too many times, that it doesn't work as well. But the fact that it does work and it does prevent severe infection, that's still really important to remember. The scientists are studying imprinting, including here at our own laboratory, because we want to know how to optimize that immune response, how to make every response just like that first one. And with the idea that eventually we can have a universal vaccine that will protect against all flu strains. And this will likely be the case also for COVID. So hope that helps to explain it.
It does. Thanks. That was a great explanation. And I know that you've done a lot of work in this area. I'm going to toss it over to Eric for the next question.
Yeah, I have a question that was just put in the Q&A, and I've been thinking about too, mainly about COVID vaccines. How long do we think that these vaccines last? So the question was, do we have any knowledge yet of how long these bivalent boosters are going to last? Is it going to be a yearly thing? Do we need it to be every 3 months? Because a lot of us have had vaccines every 6 months or so since the pandemic started. So do we have any data about this yet?
Right, so it's a great question. And some of the data I showed, for example, the vaccine effectiveness with 2 doses and 3 doses, there were different intervals of follow-up with regards to vaccine efficacy and effectiveness. And against symptomatic disease, the protection against disease does wane over time. And the studies varied in their follow-up period from 3, 4, or 5 months to slightly longer. So there's that information. Against hospitalization, one of those studies showed persistent protection at a very high level for 6 months, which was great. The other study was a little bit different, and they didn't provide much in the way of, as I recall, long duration. The other way to think about this, so there's that, and that's probably the best estimate because it's vaccine effectiveness against actual human beings who got vaccinated. Now, you'll see a lot of data out there on humoral immunity and T-cell immunity. And we know that the antibody levels, particularly after the booster, can wane over 2, 3, 4 months or so. That's just humoral immunity antibody, IgG. But if you look at T cells and any number of very advanced T cell markers, they persist much longer, 2 or 3 times longer, even up to a year and longer. And with influenza, for example, that's probably the most important cellular protectant. And Pia can speak to that with more expertise than I can. But we don't know if that's true yet with COVID. We just don't have any idea. Nor do we have any idea what the antibody, the humoral antibody level is that's protective. So even though levels may decline after 3 or 4 months, I don't know if nobody knows if they're declining to a level that's not indeed protective. So I think it's fair to say that the vaccines based on human data do protect for many months and may protect even better against severe disease. And then we have a whole lot of work to do on the T-cell immunity part.
All right.
Can I go ahead and answer one question I did see in the
Oh,
question?
sure. That would be
Someone asked about the rapid test and whether they identify the new variants, specifically BF7, BA2, and BA4. BA2, the data seem to suggest that they work fine. Of course, the problem is BA2 right now is only about 2% of disease, but that could change. BA 4.6, I guess, was the actual question. The virologists out there do not believe there's any structural reason that the rapids should not work. They work well against 5. They appear to work well against 4, but we don't have a lot of good data on actual BA 4.6. And for BF7, I'm not aware of any data, although that strain, that variant is causing about 5% of disease nationally. So,
Great. Thank you so much. Thank you to both of you for some great presentations, great information. Thank you to my co-host, Eric, and thanks to Cameron running the show over there and our ED, Catherine Flores. So, as you can see, there'll be an evaluation that'll pop up on your screen. If you don't mind filling that out, that'll really help us with, what we want to present in the future. It'll be quick and it'll be very informative for planning. Let's see, are there any other slides, Cameron? There you go. Thank you and stay tuned. We hope to continue these conversations moving forward. As we mentioned, this was number 13, and it looks like there is still plenty to talk about. So once again, thanks for joining us, and we'll see you soon.